Hello everyone, I am Wenceslao, I am a general doctor from Chile. Sebastian invited me to do this seminar about postpartum hemorrhage, that is one of the leading causes of maternal mortality. I want to apologize myself for my English, I'm sorry, I will do my best for you to understand. So let's go. Our main goals in this class are going to be two. To know and recognize the different types of PPH, that is the same as postpartum hemorrhage, and to know the importance of the early intervention and correct management of the PPH. Our route, what we're going to see this class, is a little about an introduction, the definition, the incidence, the mechanism, the general principle of management, and the treatment goals. And we're going to finish this class with a little clinical cause. So, why we decided to talk about postpartum hemorrhage in this seminar? Because it is an obstetric emergency. It's one of the top 5 maternal mortality we have seen in the title of this class. There are two kinds of PPH, the early, that is before the 24 hours, in the first 24 hours after the delivery, and the other PPH is the secondary, late or delayed PPH. That is between the 24 hours, between the first days and 12 weeks. We are going to talk about just the early PPH in this class. Well, the late PPH is caused mainly by two causes. The retained tissue, that we are going to see that is also a cause of the early PPH, and infections like endometritis is another big cause of the delayed PPH. So about the definition and the diagnosis of PPH is defined as blood loss over 500 ml, a half of a liter in a spontaneous vaginal delivery, and over 1000 ml in a C-section, in a cesarean section. But also is defined as bleeding associated with signs and symptoms of hypovolemia within 24 hours of the birth. So many times it's difficult to calculate exactly the amount of blood that we have lost in a delivery. But if we notice that there are much bleeding, but we cannot quantify the amount, but we see signs or symptoms like tachycardia, hypotension, mild restlessness, confusion, disorientation, and many others, as we have seen in CHOC class and in other seminars, this is also defined as PPH. So in the incidence, is around 1 to 5% of all the deliveries. What about Bagadi Hospital? If we calculate an average of 25 deliveries per day in Bagadi Hospital, that means that you will see many PPH, almost one per day. So you have to be prepared to make an early diagnosis and a correct management and to recognize what kind of PPH we're in front of. Now, a little about the physiological mechanisms. We have to know, first of all, that a PPH is a potential massive hemorrhage. Why? Because in a normal woman, in a normal human being, the normal output distribution in the uterus is around 3 to 5%. But this increased more than 30% in a pregnant woman. So that means that the uterine artery blood flow is around 500 to 700 ml per minute. So imagine that in 1 minute, if there is, for example, a total rupture of the artery, we can bleed more than 500 to 700 ml in just 1 minute. So this is very important to know. And what about the hemostasis in a normal delivery? It is because of two causes. The mechanical causes, that is the contraction of the myometrium that compress the blood vessels that are open because of the delivery, and the clotting system. It's the systemic coagulation factors, all the chain that we know and we have learned many times with the clotting factors, with the coagulation factors, and joints, etc. And now we're going to see the mechanism that it's very easy to remember because we can aggregate them in 4 main T. So repeat after me. Tone, trauma, tissue, thrombin. These 4 T we cannot forget anymore in our lives. And we have to remember these 4 T: tone, trauma, tissue, thrombin. We are going to start seeing each one in details. First, starting with the first T, that is tone. The main cause of PPH is this T, tone. And the main cause is uterine atony. This is around the 75% of all the PPH. So knowing this, we could be able to manage 3/4 of all the PPH. So what do you know about PPH? So I recommend you to stop the video, to put pause, and to think, what do you know about PPH? Now, the definition is the lack of effective contraction of the uterus after the delivery. As we saw, one of the hemostasis mechanism was the mechanic factor, that it was the compression of the blood vessels. So when we don't have a good contraction of the uterus, these vessels will maintain open and we can bleed a lot. So the characteristics of the uterine atony is that it's mainly in the first 24 hours. We will find in the physical examination a soft uterus, and we will see a light red blood, not dark blood, it's fresh blood. This is very important to know that it may or may not be associated with retained tissue. That is another cause of PPH, but we will see that it's commonly associated one each other. And another point very important to know is that the blood loss can be much greater than observed. That's why, because a flexed and dilated uterus may contain a significant amount of blood inside the body, no outside. So we will not see all the blood that is inside the uterus. The risk factor of the uterine atony, we can divide it in main causes. So first is the huge uterus during pregnancy, or the abdominal distension, the uterus distension, caused by multiple gestation, twin pregnancy, polyhydramnios, macrosomy, leiomyomas, etc. Other risk factor is prolonged or fast labor. All the hypertensive disorder during pregnancy, preeclampsia, HELP, eclampsia, etc., etc. Infection is another cause of uterine atony, chorioamnitis, that is preterm ruptures of membranes, and all the placenta problems like placenta previa, abruptio placenta, retained placenta or membranes. We are going to see now the second T. You remember? Tone, trauma, tissue, thrombin. So now we have seen tone and we're going to see trauma. So the trauma, we have 2 main causes. One very common, that are the perineal laceration, and the other cause is the uterine rupture. That is not very common, but very much dangerous. So the characteristics of the perineal laceration is that it's immediate postpartum. Yeah, the uterus, we have to rule out the uterine atony, that is the main cause. So the uterus will be hard and well contracted. We will see that the placenta may not be, the placenta will be completely delivery. We will see all the placenta, and we will see the lacerations. We will be able to visualize the lacerations or tears. So now I disappeared of the camera to allow you to see better the slide, and we will see that the perineal lacerations has 4 degrees. The first degree is the laceration of vaginal epithelium or perineal skin only. That means that only the skin and subcutaneous will be affected in the first degree. In the second degree is the involvement of the perineal muscles but not the anal sphincter. So the fascia and musculature of the perineal body will be affected. The third degree is the disruption of the anal sphincter muscles, and we have 3A, 3B, 3C, but it's not very important. And the fourth degree is the third degree tear with disruption of the anal epithelium as well. So we will see a totally communication between the vagina and the anus. And this is important to know because we'll change the management. So the first and second degree tears, we have to suture, and it's very easy. The majority of you will do it, or you have done many, I don't know, but we have to suture in the same place. We don't have to move the patient to anywhere. And the third and fourth degree tears, we have to know, because of the sphincter is affected, we have to make a surgery. So I put antibiotics and sutures down in the slides because in the third and fourth degree tears, we have to put the antibiotics prophylactic of a normal surgery, and the suture it has to be continued and with a reabsorbable suture in the first and second degree. So the second cause of trauma is the uterine rupture. As I told you, this is a rare event but very dangerous, and we mix a little two pathologies that are postpartum hemorrhage and obstetric hemorrhage before the delivery. So the clinic of the uterine rupture, we have to know it very good because it's very dangerous, as I told you. We will see during the labor, if we have a uterine rupture, we will have immediately a fetal heart rate abnormal pattern, particularly bradycardia. So we will have a fetus suffering. Then we will see a loss of station. The baby will go up, and of course, because it's a rupture of the uterus, we will have abdominal pain, uterine tenderness. The contraction of the uterine will stop because it is broken. We will be able to see the change in uterine shape, and if the uterine rupture is huge, we also can palpate the parts of the fetus. Of course, because as we have seen, the uterine artery have around a flow between 500 and 700 mL, we will see hemodynamic instability very fast. And of course we will see bleeding. That's why we are talking about postpartum hemorrhage. So here we have a photo of the postpartum hemorrhage. As we can see, this image shows us in the lower segment. That means that the main risk factor will be to have a previous scar. So the risk factors, as I told you, the first and main is the previous scar. Then if we made an instrumental delivery, and a fast second stage is also a risk factor. Any kind of dystose, hyperdynamia, a creta placenta that we will see a little after, and the Gristeller maneuver. Now, a little stop during this class. I invite you to put pause in this video, but before, to think, where is my country? I come from Chile, so it's around, say, Asia, Africa, North America, South America, Europe, near Australia. So put pause and think, where is Chile? And now we're going to see that my country is in South America. So let me show you where it is. Here is Chile, in the west coast of South America. Sorry. We are next to Argentina, next to Bolivia, next to Peru, etc. So this was a little break. We are in the middle of our route. We are going Matatu, Pole Pole, but we are going safe. So let's continue with the third T. We have seen tone, trauma, and we're going to see now tissue. So the first cause of tissue is retained tissue. What do you know about this? So again, put pause and think about what do you know about the retained tissue, retained placenta, and then we continue. So the definition of the retained tissue is the lack of expulsion of the placenta within 30 minutes of delivery of the infant, of the delivery. So, the placenta delivery incomplete, we will see that the placenta, we will see when the placenta is out that there is no complete. And as we saw, it could be associated with the uterine atony. We will see that there is a spectrum between trapped and accreta placenta of the retained tissue, starting with the trapped placenta, the adherens placenta, and ending with the accreta placenta. This spectrum will increase the morbidity from trapped and accreta. So the retained placenta, you're going to see the three main causes of the spectrum. First is the trapped or incarcerated placenta, that it could be defined by separated placenta that has detached completely from the uterus but has not delivered spontaneously, and then the placenta adherens, that is the placenta is adherent to the uterine wall, but it would be very easily to separate it manually. And then the third step of the spectrum, that is the most complicated, is the placenta accreta, that has his own spectrum. So we will see that inside the placenta accreta, that is defined that a pathological invade of the myometrium for the placenta, that it cannot be cleanly separated, will have his own spectrum between starting with accreta placenta, then increta, and then percreta. This is not the goal of this class, so we will see just this. What about the risk factors of the retained tissue? Is to have, well, as in many situations of, of gyne to have a previous event is a risk factor to have it again. So the first and main risk factor to have a retained tissue is to have a previous retained placenta. Of course, then to have a previous scar. The two other risk factors are the preterm gestational age, use of ergometrin, that we will see a little what it is in the end of this presentation, the uterine abnormalities, all the hypertensive syndromes like preeclampsia, and the velamentous cord insertion. I don't know if you know what it is, but again, this is not the goal of this class. And well, another statistic risk factor is that the maternal age is over 30 years old. Now we are going to see the fourth and last T, that is the thrombin. That is we can define it like coagulopathies that can be acquired or inherited. The acquired coagulopathies are all the hypertensive syndrome, preeclampsia with severe features, HELP syndrome, placenta abruptio, amniotic fluid embolism, sepsis, or a very common acquired coagulopathy is the intravascular disseminated coagulation. And the inherited coagulopathy as von Willebrand disease or hemophilias. That we can usually diagnose this kind of coagulopathy asking to the patient about her history. For example, if she easily bleed before the delivery, what about their menstruation, if she has before hypermenorrhea, etc. So the characteristics of these 4T, the coagulopathies, we will see contracted uterus again. So we always have to rule out the uterine atony. And as I told you, the most important thing is to ask for the patient a good anamnesis. So we will see history of coagulopathy, hypermenorrhea, and other bleedings, epistaxis, etc. So this is the second stop of the class. It's a little break again. So as I told you, Chile was a very thin and long country. So the climate will be different between the north and the south. So in the north, we have the driest desert in the world, that is called Atacama Desert. And here is a landscape of the north. But now, if you see, in the south, we have many volcanoes, many national parks, many lakes, Actually, we have more than 200 volcanoes. No, more than 1,000, I think, but not many actives, just a few ones. This park is called Patagonia Park. It is very beautiful. Now we're going to see the general principles of management. There are 4, and then we are going to see each one. So the first of all is to quantify the blood loss. Then we have to know that the timely diagnosis and early intervention is the key for these situations. And the third point is the teamwork. We never have to work alone. That's why we work together with the nurses, with the doctors, with the consultant, etc., etc. And the fourth main pillar of the management is to monitor, to continue monitoring every 15 minutes or every 20 minutes as you can, as common as you can, and the vital signs, and to ask for laboratory and to see the laboratory results. So we're going to see each one. First, to quantify the blood loss. So there are measurement containers, but it is very difficult and they are not very available in all the hospital. And it's also very difficult because the patient maybe it's with pain, is moving a lot, so it's very difficult to graduate it in a measured containers. The second way is to make a difference between the tissues dry and wet. So if you put tissue to contain the bleeding, then the tissue will absorb much blood, and you can see the difference of weight. But these two things that I've told you, it's a confused system. So I recommend you to use the vital signs. As we have seen in the shock class, there are different categories of shock, and each category have their own characteristics. So I recommend you to use the heart rate, the blood pressure, etc. The second pillar and the second general principle is to have a timely diagnosis and early intervention. This is critical. Why? Because the 90% of the death due to PPH occur within 4 hours giving birth. So the first 4 hours, we will see the 90% of the death because of PPH. And of course, the early intervention may prevent the shock. The third general principle is the teamwork. This is very important. You always have to remember to ask for help. I put many professionals that can help us. The obstetricians, that are the consultants, the midwives, nurses, anesthesiologists, hematologists, and blood bank personnel, laboratory medicine personnel, surgical subspecialists like vascular urology, and interventional radiologists may be involved in managing PPH. So it's very important to never work alone. And the fourth and last general principle is to monitor bleeding, vital signs, and laboratory results. Why? Because it's critical to assess the best approach and aggressiveness of intervention and require bedside evaluation by the provider. Well, this is just a recommendation, but if you have a mild PPH, you have to ask for complete blood count, coagulation studies, potassium, and ionicide calcium levels, and urine. This is the basic. Or the basic, well, if you are in a rural center, probably you will not have all of these studies. But if you are in Bagadi Hospital or in Quiniata Hospital or in a good hospital, this is the minimum that you have to ask. But if you are in shock, you have to ask for all the battery exams for shock. Now the treatment goals. So we're going to start with our treatment goals, and then we're going to see what to do specific, in order, etc. So the first treatment goal is to restore or maintain adequate circulatory volume to prevent hypoperfusion of vital organs. So it's to prevent the shock and to restore the circulatory volume. The second treatment goal is to restore or maintain adequate tissue oxygenation. That is is basically the same. It's complementary to the first one. The third treatment goal is to reverse or prevent the coagulopathy in case that we are in case of the fourth T, the coagulopathy, the thrombin. And the fourth treatment goal is to eliminate the obstetric cause of PPH. We're going to see each one and we're going to see what to do specifically. What about the general management? So first we have to start with the general management, then the pharmacological management, and finishing with the surgical. That's why it's very important to ask for help to the surgical team, to the consultant, etc. So first, the general management. What to do? First, get help and notify obstetric hemorrhage team. If you don't have an obstetric hemorrhage team, you have to ask for help to another persons, to all the personnel that we have seen. Second is to continue to monitor vital signs and quantify blood loss. If we see that the saturation with the pulse oximeter is under 93%, we have to put oxygen. Then, very fast, we have to ensure intravenous access with 2 large gauge catheters and to ask for laboratory request. This will allow us to put normal saline very fast. And the first step, and as we have seen, the 75% of all the PPHs are because of the postpartum hemorrhage. Sorry, it's because of the uterine atony. So we have to palpate the uterus, and if it's soft, we have to start immediately with the bimanual uterine massage. Then, once you have the 2 large catheters and you have requested the laboratory, you have to start with the volume resuscitation. That means that you have to start putting normal saline and ringer lactate. This management is the same for many situations. We have seen this management in detail in the shock class. And well, with the rule 3-to-1, if we have to ask, thinking in the future, for the blood and that products to transfuse, if we never know if we will need it in the future. So remember, if we have unstable hemodynamic and we have put more than 3 liters of normal saline, we have to ask for 1 unit of blood. Or also, if we see if after the laboratory request we have the results of hemoglobin under 7 grams per deciliter, we have to transfuse again 1 unit. And then after the volume resuscitation, we have to continue seeing if we have laceration, tears, if we have retained products in the vagina or in the uterus, if we have uterine inversion, that we have not seen this before, but when you usually pull the placenta, the uterus can invert. So this is a situation very complicated, very delicate, and we can see it because we will see the endometrium very near the vagina. So we have to, once we diagnose the laceration, the retained products, or the uterine inversion, we have to treat as appropriated. For example, if we have a laceration 1 or 2 degree, first or second, we have to repair it. If we made an episiotomy, we have to suture it, or if we have a uterine inversion, you have to reposition. You have to make a reposition of the uterus. Now we're going to see the second step of the management, that is the pharmacological. We have here a table with the uterotonics, that are the oxytocin, misoprostol, methylorgonomine, and carboprost. That is not very available, but when you have it, it's very good. We have the pharmacokinetic and the adverse effect of each one. I don't want to read each one because it's going to be very boring, but you have to read it because this is very important, especially the start time of action of each uterotonic and also the adverse effects. So here we have an order that we can follow to the correct management of the PPH. So starting with oxytocin, here at right we have the doses, but it's not the idea to read each one. But starting with oxytocin, then continue with methylergonovin, then misoprostol would be a great option, and finishing with carboprost. That is, as I told you, is not very available, it's expensive, but probably if we have not stopped the bleeding with the 3 first options, we have to refer the patient to another hospital that has carboprost or have surgery or have another options of treatment. When we have a massive hemorrhage, we always have to put prophylactic antibiotic. This is very important. If we have a mild PPH with an episiotomy or laceration, it's not necessary. Not in case that the surgery is not needed. But in other cases, when we have a massive hemorrhage, we always have to use prophylactic antibiotic. So this is the third step of the treatment of PPH. We have seen the general management, then the pharmacological management, and now the surgical or instrumental management. So starting with the instrumental or intrauterine tamponade, that we will see the technique soon. It is very available and it's not very difficult to do it. And then we just to know that there exist 3 other options. That is the suture B Lynch, then the embolization, and finishing with the worst and last option, that is the hysterectomy. If we don't find any case to stop the bleeding, we will have to make a hysterectomy. So now the instrumental or intrauterine balloon tamponade, that we have the indications and contraindications, and in the next slide we will see a video that shows us how to put it and everything. So the indications is when uterotonic drugs and bimanual compression of the uterus fails to control bleeding. Its use is indicated before resorting to more invasive surgical approaches requiring laparotomy. Yes, as I told you, well, first we have to make the general management, then the pharmacological management, and then we have to put the intrauterine balloon tamponade. And then if it not results, we have to go to surgery. Then we have to know also the contraindication. For example, any patient allergic to components of devices and in clinical settings where tamponade is unlikely to be effective. For example, bleeding from pelvic vessels or cervical or vaginal trauma, uterine abnormalities that prevent effective balloon tamponade, suspected uterine rupture, cervical cancer, and purulent infection of the vagina, cervix of uterus. Those all are contraindications of the uterine balloon tamponade, and in these cases, we should go from the pharmacological management directly through to a surgery. So here we're going to see a video of this technique.
Grace is a midwife at a local health center. Every day she helps deliver babies. Today at the health center, Mary is in labor. Grace knows that some bleeding after a baby is born is normal. However, if a mother's uterus does not contract after the birth of the placenta, the bleeding can become severe. This is a life-threatening emergency called postpartum hemorrhage. Uterine balloon tamponade, or UBT, is a medical procedure which helps to stop severe bleeding and can save lives. Grace has a ready-made UBT kit which has a Foley catheter with a one-way valve inserted in the end, a large syringe, 2 pieces of string, and a condom. She also has gloves and clean water. She stores the UBT kit and equipment in a clean, accessible place. Grace helps to deliver Mary's baby. then gives drugs to help the uterus to contract. Grace gives 600 micrograms of misoprostol, or an injection of 10 units of oxytocin. But once the placenta is delivered, Mary begins to bleed. Grace performs uterine massage to slow the bleeding, and then checks that the placenta is whole and that no tissue has been left inside the uterus. She makes sure the bleeding is not coming from a tear in the cervix or vagina. But Mary is still bleeding heavily. So Grace empties the bladder and gives a treatment dose of misoprostol or oxytocin to help contract the uterus. Grace also continues to massage the uterus. Mary continues to bleed heavily. The normal methods to stop the bleeding have failed. Grace knows that Mary is losing too much blood and this is now an emergency. Grace must act quickly. She uses the UBT kit. Grace makes sure she has enough light so that she can see clearly. She washes her hands with clean running water and soap, puts on clean gloves, and opens and assembles the UBT kit. She inserts the catheter halfway into the condom balloon. She carefully wraps both pieces of string around the base of the balloon, tying it tightly to the catheter, making sure it will not come loose. She draws clean water into the syringe and attaches it to the catheter at the opening used to fill the smaller Foley balloon, which is at the top of the catheter. She inserts the UBT into the uterus. She pushes 15 ml of clean water through the catheter into the Foley balloon. Grace then draws water into the syringe and attaches it to the one-way valve into the catheter. She pushes water into the main condom balloon inside the uterus. As the balloon fills with water, it inflates. She repeats this action using as much water as necessary to stop the bleeding. Each time Grace removes the syringe to refill the balloon, the one-way valve in the catheter prevents the water from coming back out. If a UBT kit with a one-way valve in the catheter is not available, a clamp can be used on the catheter to prevent the water from coming out while refilling the syringe. As Grace continues to add water, the balloon inflates and puts pressure on the inside of the uterus, which is where the bleeding is coming from. This pressure stops the bleeding. Grace then gives Mary a single dose of antibiotics to reduce the risk of infection. If the bleeding does not stop, Grace should check the UBT is correctly positioned and that there is no other source of bleeding. The balloon must remain inside the uterus for 6 to 24 hours. Grace regularly checks to be sure that Mary is no longer bleeding and that her uterus has contracted. She also regularly checks Mary's vital signs, such as heart rate and blood pressure, while the balloon is in place. In order to remove the UBT, Grace attaches the syringe to the catheter and slowly draws out 1 or 2 syringes full of water to lower the pressure without taking out the balloon. She watches for 60 minutes. If the bleeding starts again, Grace must refill the balloon with clean water and arrange for Mary to go to the nearest hospital. If there is no bleeding, Grace uses the syringe to remove all the water from the balloon deflates the small Foley balloon, and then removes the UBT from the uterus completely. In most cases, the UBT will successfully stop the bleeding. Mary and her baby are safe and healthy.
So I really hope that you have enjoyed the video. It's a very good summary of the management, and well, it includes also the pharmacological steps and then the technique of the intrauterine balloon. So it's a very good video. I hope that you have enjoyed, and then you will be able to see this video many times that you want. So finishing this presentation, and after we are going to see a little clinical case, we have the living golden potatoes. As Sebastian has taught to you, these are the concepts, the main points that you have to remember forever. So first, the PPH is an obstetric emergency, and you will see many in your life. Remember that it could be a potential massive hemorrhage because of the cardiac output increase in the uterine during the pregnancy. Remember always the 4 T's: tone, trauma, tissue, thrombin. Repeat: tone, trauma, tissue, thrombin. You have to repeat many times to don't forget it. And then the management, remember that time and early intervention could save lives, and always, always, always ask for help. Remember the teamwork. These are the little golden potatoes, the main concept that you have to remember. So now we're going to finish this class with a little clinical case to see if we have understand, if we can manage by ourselves these situations. So a 24 years old woman, primigravida with 39 weeks of pregnancy, comes to the labor room with low abdominal pain in second stage of labor. You attended the delivery and you took all the ways of prevention of PPH, with the oxytocin after the delivery of the placenta. Well, everything is going well. After 2 hours, you go to check her and you notice that she's bleeding a lot. The vaginal tissues are completely wet with light red blood and clots. The mother is feeling tired and without energy, and you know her confused. You know that she is a mild disorientated, etc. So, what do you have to do in this case? So I invite you to put pause in the video and think all the steps that we have seen. And now we're going to see each step. So first, ask for help and notify the obstetric hemorrhage team. I hope that you have remembered this. Then continue to monitor vital signs and quantify blood loss. It's the same that we have seen in all the presentation. Third, we have to ensure intravenous access with 2 large gauge catheters and ask for laboratory request. Then the physical examination of the patient. If it's abdominal tenderness, how's the consistency of the uterus, and if we see perineal lacerations. Yes, after you have done these steps, your results are: you think that she had lost around 1.5 liters of blood. The heart rate is 126 beats per minute. The blood pressure is hypotensive, is 86 and 64 milligrams of mercury. The saturation is 92, and the respiratory rate is 21 per minute. You noted that, as we told, mild disorientation in the patient. In the physical examination, the abdomen has a soft uterus, not contracted, and in the umbilical level. So we have now almost the diagnosis made, and we see no lacerations, no tears. So which are the most likely diagnoses? So put pause again and think, what do you think about this case? The first diagnosis is hypovolemic shock, category 3. I hope you to remember the class of shock. It's very important to see it before this class. And then we have a PPH, a postpartum hemorrhage, caused by uterine atony, the 75% of all the PPH. So let's continue. So what about the management? Again, and in all these slides, you have to stop the video and think what you would do if you are in case of this situation. So stop the video, pause the video, think, write what you would do, and now we are going to see each step. So first, once we have made our diagnosis of uterine atony, we have to start immediately with the bimanual uterine massage. Then we have to continue with all the management of the shock that we saw in the shock class. So, but in summary, we have to put normal saline, the amount of the mLs that we have to put of normal saline, we will see depending of the category and depending of the amount of blood that you calculate. So normal saline, oxygen because it's saturating under 93, urinary catheter to see the urine output, and always remember to continuous monitorization. Then the management of PPH, starting with oxytocin, the methylergonobin, the misoprostol, and then if you have carboprost. And in this case that we have shock, we have to remember to add prophylactic antibiotics. I hope you have put all these steps in the management when you pause the video. Then, after 30 minutes, you have used oxytocin and methylergonobin. You didn't use the next step in pharmacological treatment. You have used also 3 liters of normal salines and oxygen, and in the next monitorization, you see the uterus now is hard, well contracted, the heart rate is 102, so the tachycardia is less than before, the blood pressure had increased, the saturation is now 98%, and the respiratory rate is under 20, is 18 now. So you have saved her life, probably. So now what? Now what? Very important. I hope that you have the answer very fast. Always continue monitoring these patients. You don't have to forget these patients, and now that she's okay, you have to go and forget about her. No, you always have to continue monitoring these patients. This patient is still an emergency. So in any second, it could be again worse and worse and worse. So now we have finished this class, and the final question for you is, do we achieve our main goals that we proposed in the first slide? I remind you that the main goals was to know and recognize the different types of PPH and to know the importance of early intervention and correct management of PPH. So you have 3 alternatives. I hope you to answer the letter C. The A is not at all. I have not learned very much about PPH. B is could be better. And C is yes, we totally achieve our goals. So I hope you to mark the letter C. And this is all the class. This is the postpartum hemorrhage class seminar. Remember, this is one of the leading causes of maternal mortality. I am Wenceslao Cejers, a general doctor from Chile. Thank you very much for your attention. Hope that you have enjoyed and learned a lot of postpartum hemorrhage. See you next time.